Welcome to the roundtable discussion, Leadership in Organizations, 21st Century Challenges. Today we'll be discussing several topics related to leadership in healthcare in the 21st century. Amongst them, the following I will address to on my panel of four. How does the recently passed Healthcare Reform Act affect your hospital or organization? We know the landscape of healthcare and the marketplace is changing dramatically. How can you focus on how you, as a leader, will position your organization over the next few years? Let's begin with you, Cindy Lord.
Primary care. We all know that that's going to be a huge challenge, and yet PAs, the birth of the PA profession was in primary care, and we continue to expand in that area. Having our students who have been very excited by going into specialties and have tended to follow the House of Medicine into specialties with salaries and technology and kind of new innovations. It's been a little more difficult. However, I think with the new healthcare reform and the need to take care of those patients today, we're going to have an increased focus on primary care. When you look at how PAs practice medicine, they practice in the team model. So when you look at the patient-centered medical home, the way PAs practice, the physician is the leader of that team, and so that's not a new concept for us. PAs are usually an integral part of the coordination of patient care. Many times, even if PA is in a specialty practice, they will be the ones that will be doing the primary care and coordinating with all the other specialties. I know as a primary care PA myself, I'm the one who's coordinating with patients who are seeing the cardiologist or the rheumatologist and coordinating those their care there. I think another challenge that we face is we have to close the gap with reimbursement and with incentivizing physicians who precept PAs, medical students, and nurse practitioner students. We need to be able to have those quality preceptors. You can't just put people out into primary care. They need education. And to get them educated, we're going to need physicians, physician assistants, nurse practitioners, all of those people to be able to do that education. And to do that, we're going to need to incentivize them by either reimbursement, improved reimbursement, similar to those students who will graduate and go into those fields. They're going to need to be able to pay back loans because the students today are entering with huge debt from their undergraduate, and that becomes an issue. So,
thank you. Cynthia?
Yes, well, I represent a different organization because we represent the provider. So we try to help the providers, and our advice to them is obviously with the healthcare reform, technology. The one thing that we're pressing on is these EMR systems, especially at the physician level. And being that we deal with quite a few of medical oncologists across the country, we're empowering them to bring on nurse practitioners and PAs so that they can see the patients and new patients, and the nurses and the PAs can take care of the patients. And we're really pushing the e-prescribing for our pharmacies because we need to put the e-prescribing with follow through on the drugs because the compliance on the drugs is very important. In cancer care, there's quite a few oral drugs in the pipeline, and those drugs need to be monitored. So that's the other challenge, and we're looking at this in our specialty pharmacy. That's another hat that I wear, that we follow the patient with the drugs.
I see. Could you talk a little about that?
Well, if a patient gets a prescription for a drug, there's a percentage that they don't go and they get it filled. So if it goes through a specialty pharmacy, they'll do all the pre-certification, find insurance for them, or find their pharmacy benefit plan, understand it, know what their co-insurance might be. Or if it's an indigent patient, obviously there's programs where you can get drugs for the patients. But then the key is to make sure the patient is taking their medication, because that's part of the whole continuum of the care. And they call the patient up. Did you take your medication today? What were your if you had side effects? And they relay this back to the physician. That's why it's so important for everyone to have these EMR systems. It's the only way you can communicate, because writing it in a chart is just not going to do it. And then it could coordinate with their lab values when they go to get their lab, especially in a cancer situation where it's the hematology and the oncology. But the biggest problem with a lot of the cancer patients are with the oral drugs, they don't follow through, they don't take them.
Thank you. Fred,
Yes.
I know that you're in a different setting, so it would be exciting to
Yeah.
hear your take on this.
Well, for the benefit of the class, I'm the executive director of the Long Island State Veterans Home, which is a 350-bed long-term care facility. Also, we provide adult day health care as well. The question as asked about health care reform, I do have concerns, and we're living in an aging population. I think the class knows that the baby boomers are here. They start in 2010, which is now, and will keep on coming till the year 2030. And with the aging population, I don't think we're prepared as a nation as it relates to long-term care. When you talk to large populations of people and you ask them about long-term care insurance, less than 5 to 6% of all Americans have some kind of long-term care insurance. And I'm not really clear, based on what I've heard so far about the President's proposed Health Care Act, if the issue of long-term care was addressed. We've heard snippets of it, Nadia, more specifically this whole notion of bundling and how the President and Congress want to avoid things like readmissions. So we know for about 3 or 4 diagnoses, acute MI, fractured hips, etc., they're bundling the payments. So right now, as a long-term care provider, if I build a Medicare program, I'm pretty much guaranteed payment in about 5 to 6 days. Under the new proposed methodology, the patient will go to the hospital. Hospital will be paid by Medicare for both the acute phase and the post-acute phase, and then that hospital has to do a deal with the nursing home locally, and then the hospital winds up paying the nursing home. So I can tell you from our perspective, our profession, the long-term care profession, we're not really happy about that from the perspective of cash flow in my organization. So knowing that I can electronically bill Medicare and get paid in a reasonable amount of time leads to the viability of my organization. Knowing that I have to collect from a hospital who might not be in great financial position leads me to worry. And on a small scale, I'm a specialty nursing home from the perspective that I'm honored to care for military veterans who've been honorably discharged and their spouses. When we looked at our statistics in preparation for this, last year I did 250 admissions. Not a lot for a nursing home my size because we tend to do a lot of end-of-life care as opposed to short-term rehab. But those 250 admissions came from 45 different hospitals. So now, in my preparation, do I now have to have agreements with 45 different hospitals and expect payment and manage payment from 45 different hospitals for the care that I think I do a good job rendering? So that's just a small snippet of the many things that will come out of the 2,000 plus pages of this act
2,800 pages.
that a lot of us didn't realize. So, you know, overall, I think we rely on government too much. When you look at the 17,000 nursing homes in the United States of America, approximately 80% of those who are receiving long-term care are on the Medicaid program, or as I like to call it, the public option. So, so it's a big issue, and I'm not sure that we really addressed it in this round in Congress. And I think there's going to be an awful lot of refinement that has to be done to the bill over the next 3, 4, 5 years.
Thank you. Craig?
Yes. I really came to advocate for technology because I think that's an answer to much of our problem. After today, I think I should rethink that. But the reality is, I really think that we're in trouble. I think that there's no infrastructure to quickly turn us back to a primary care setting. The physicians are not there, and infrastructure to feed it, the incentives for people in healthcare to go to the primary care is just not there. Having said that, I believe that if given time and given the dollars, we can make that happen. But we have to go that route. There is no way that we can take what we have now, and I'll call it acute episodic care in this country, that's very expensive, and then just quickly turn it over to a community-based healthcare system, and that's where everyone wants to go. But if we took this is statistics, I think is correct, they said if we took every physician that was graduating from medical school now to the year 2030, we still would be short of primary care physicians. So the void is there, and so how do we make up the time, and how do we create the infrastructure? I just came back from the World Healthcare Congress, and everyone talked about the need for PAs and NPs and nurses, and building a community-based primary care health system. And you can call it medical model, homes, and all that thing. It's all going to play a part of it, but it's not here.
It sounds good, right?
It sounds good.
Right.
So we have to figure, how do we entice physicians and PAs and NPs to go into primary care? The reason that the physicians left, because it was not sexy, and it didn't pay, and all that time and effort and education, they don't want to make $90,000 or $100,000. So that's the problem. So there's got to be a new force that goes into the community health, and I would take it. I know we need physicians, I know we need NPs, I know we need PAs, and we need nurses, but I would go even further than that. Some of the studies that I've read and been involved in are using community health workers, and it's key. If you're going to go into the community, there's no one better than to pull from the community and train them at a skill set that they can go and help their fellow individuals in the community and do screenings in the city with the help of healthcare, but it keeps the cost down. There are models in other parts of the country that work very well there. So I'm saying right now, I'm nervous about the process, and I think it's going to take some time and a lot of money to go from the acute episodic care back to primary care.
Okay, I'm going to ask the students now if they want to ask any questions at this point in time of any of the speakers, and then we'll move on to the next question. So we're going to take a brief pause in the questioning. While we have some of the students coming in, I know that, Craig, you've been involved with e-technology in third world countries.
Yes, I have.
And, although we're not, quote, a third world country, certainly the concept of having this, this mid-level healthcare worker, if you want to call it that for lack of better terms, in a country where we have a great many unemployed right now, and we're also questioning the educational system as a whole, namely undergraduate school. And I think even on PBS last night they had someone from the Gates Foundation talking about development of more community schools, local schools and community colleges, and developing skills that for these students who could then possibly do what you're describing. Certainly the incentive has to be there, and it is a difficult thing. Do you think that there are already things in place, vehicles in place, that we could start to do that?
Yeah, there's actually federal programs that train community health workers now. They're certified community. Let me go back. I do work in Kenya, and to implement this kind of technology and to offer basic primary care to the people in Kenya is very simple, because they're starting with almost nothing. What we're asking the American population to do is to go from the ultimate health care back down to the basic health care. And that's difficult to do. It's like driving the Lexus and then saying, well, next year you're going to have the Ford. So it's hard to swallow sometimes. And we have to retrain our thoughts and our practitioners to understand that we don't always need high-level technology and to take people into the hospital and do very costly examinations.
Yes, I think I'm sorry, go ahead.
To add to that, our system, we have lots of other healthcare workers in the system that we don't utilize well. Licensed not nurse practitioners, but LPNs and social workers, or even medical assistants in an office. Because we've been so siloed and territorial about how we practice medicine, we've garnered these duties in here where they could be parceled out. We have to change the whole structure of how we even provide care. This 15-minute visit and the 30-minute visit. When, don't you think it'd be great if you put all your diabetics together? Don't you think the person whose diabetes is well controlled and you bring them in and they talk to the other people, wouldn't they be more inspirational than we sit in a room for 30 minutes with you've got to eat better, you've got to lose weight, and their glycohemoglobins are still high. And so utilizing a lot of these people that we have, again, de-siloing, taking apart those silos and having people, the social workers, again, nursing assistants or medical assistants, there's things they can do. We've just said, no one else can do this but me. And really use your medical providers, physicians, nurse practitioners, and PAs to provide that more critical care that really, it's a different type of care than all of this prevention and all these other things. But I think we have to change our model of how we even see patients, group visits, phone calls, smoking cessation, tobacco, one of our leading problems, healthcare in this country. And what do? Take a piece of gum, put a patch on. All the data shows the people who've done best have had constant phone calls. How are you doing? What support systems there? Keep following up on a weekly basis. And we don't do that. Who's going to do that? We write the prescription and out they go, and then we're surprised why they don't stop smoking. So I think there are some things that we could do, but it's a change. It's a cultural change for us.
We're having a couple of comments here I think we should share. Already someone is saying that that's innovative and yet so practical. It's there. We have a question from one of the students. I think it goes along with what you were saying, Craig. It says, aren't we going back to the past with needed family practitioners and avoid many of the specialty referrals that occur today?
Right. But if you go back into the 70s, when I entered academia and healthcare, you talk about health promotion, disease prevention, and it was under the Carter administration and the Institute of Medicine.
Right.
And it was, all the money was flowing into the universities like we have now with the stimulus money. And people were working great ideas and wrote curriculum and interdisciplinary education and the team approaching the patient instead of one individual. And in a matter of years, it just kind of faded away. And that's my concern with what's happening now, because the effort to get back to that basic medicine, right, if I can call it that, is going to take a lot of effort because there are so many people that don't want to go back. And it's going to be hard. They can put a lot of money in it, but I wonder in 5 years from now when we have a re-election, is it going to change back to what it was, just because it's so difficult to get back into community and primary care. And turf, scope of practice. We have it between the PT, the OT, and the athletic trainer. Scope of practice. You're doing my job. This is my. So it's tough. We don't share.
I think this might be addressed more to you, Fred. Should not healthcare reform address not only access and quality, but also the increasing elderly numbers and providing less expensive schooling for primary care docs, PAs, and NPs?
The answer is yes. As in addition to being a healthcare executive, I'm going to be the father of a first-year medical student next year, and whose daughter called me from college to say, Dad, now that we have this new healthcare act that just passed, what should I do when I grow up? And I told her, do what you love, and you'll never work a day in your life. But the reality of it is that when you think about the amount of formal training to become a doctor today, do you want to do that for a $20 copay at the end of your career? So I think it is a big problem. I think Craig's right. We have to provide incentives, and we as Americans are not ready for what's coming down the pike. The two major words I leave with the group tonight is access and convenience.
We're going to get there.
And that's what it's about. Plus, the internet has really changed the way medicine has to be delivered.
And I see everyone nodding their heads as
well.
Yeah,
and I'm the brother-in-law of two physicians, one that practices internal medicine with a specialization in hypertension, and the other one who practices pediatric oncology. And it is not unusual for either one to see a patient with a stack of things that were printed, right off of WebMD or whatever other internet site. So our patient population is more demanding, they're more informed, and more misinformed from all the TV commercials, promoting all these great medicines. If you listen to the side effects, why would you even take the drug? So as a nation, I like to think we're headed in the right direction. But, you know, today, I look at healthcare executives who, in hospitals, you know, when you went in for a certain illness or injury, they used to take you to the third floor to the radiology department for a CAT scan. Now we're putting MRIs and CAT scans right in the emergency room. That's not less expensive, that's more expensive. And, you know, somewhere in this conversation, tort reform has to come up tonight, because I don't think we've done a good job addressing that as well. And until we have lawsuit after lawsuit after lawsuit, a lot of this defensive medicine is not going to go away, no matter what the president is trying to achieve. So.
We have one more question, then we'll go on to the questions that we have. Cynthia. Cynthia, do you feel that care will be compromised by going back to the family practitioner model, being more in the specialty area?
Well, I mean, again, you know, if you have cancer, you know, you're hoping that your family practitioner doctor would send you for all the appropriate tests, and then, of course, refer you to a medical oncologist, if that's the case, you know, to be staged and to get the treatment. It all depends on if that family practitioner physician is going to keep that patient too. I mean, I've seen that over the years where people are not diagnosed properly, and then maybe if it was caught early, it could have been stage 1 or 2 versus 3 or 4. So it's hard to tell. I just feel that all these physicians are going to be so busy. I'm scared as a consumer and as a baby boomer also. It just scares me because I see what's going on now in these facilities. I travel this whole country and I'm in and out of cancer centers, and it scares me what I see now. So I can't imagine with this reform. The only good thing that came out for cancer patients in this reform is the government has in those 2,800 pages that if there isn't any choice for a patient and a trial could be their only choice, now the insurance companies have to pay for the clinical trial. And I think that, as a cancer care advocate, I think that was wonderful. Mm-hmm. At least they have a shot then of getting on a clinical trial.
Well, let's go on to the next question then with you. We'll start with you. How has the delivery of healthcare changed? Now, what specific changes do you think support the current administration's goals related to access to care and quality of care?
I think it's going to take longer. I think that even if you get diagnosed with something, it's going to take longer to get to that specialty physician. If you have to go to a specialist, I think they're going to run an army of tests. You know, I think, and there again, it goes back, because I'm just such an advocate for these electronic medical records. I do agree with that, because I've seen so many errors by not having that. In fact, I was just at a meeting yesterday, and I spoke to a large hospital here in New York where they had their Medicare, Medicaid audit, and it's a big, large hospital system, and they had 9 patients that they got fined for. So that's like, you know, $10,000 a patient because the records weren't right. They didn't have the proper documentation while they were being audited, and that's critical. And I asked these 2 executives, well, what kind of EMR system are they using? And they basically didn't like their EMR system. But, you know, you pay for what you get for it, too. Mm-hmm. And now they got to pay, you know, a $90,000 fee. I just think for a patient, it's going to take longer to get the care.
So it's going to take longer, but what about the quality?
Well, I'm hoping that with all these changes that we do have better quality, but I'm questionable about that. Mm-hmm. Because that's where I think the nurse practitioners and the PAs come in. I think if these practices empower and bring on these types of physicians and help, that will help the physicians, because it'd be better for physicians to bring in a nurse practitioner and a PA than other doctors, because our doctors want to be partners, and I think they could run a nice practice if they're surrounded by nurse practitioners and physician assistants. I'm actually seeing that trend in the oncology practices today.
I see.
Doctors are bringing in more nurse practitioners because they can still see patients, bill for them, write scripts.
Well, there are practices in which PAs are partners as well.
Yeah, well,
there are PAs who are own practices. Now, Cindy, want to respond a little to that? The quality of care, how has it changed in terms of access? And
well, I think one of the things we're seeing, obviously, are we're living longer, and we're seeing much more chronic disease and continuing that chronic disease out for many more years. And with that, of course, the challenges that we see. And I will echo what you said about there's no focus anymore on prevention. All we do is chase disease. And with those kind of diseases, when you look at, just take obesity, again, one of the leading
causes of lots of millions of dollars being spent on obesity and all the sequelae of obesity. That may even, I heard today CNN talk about, that may even impact the security of our country. Did you know that last year we spent billions of dollars, that it was amazing, that number, about talking about in the 1940s, in World War II, many of the men that went into the military were washed out because they were too thin and they weren't healthy enough. And so the federal government stepped in and Congress stepped in and said, we've got to implement school-based meal plans, school nutrition plans. And of course, we've done that so well now that they've all come out obese. And now the washout, the number of men and women that are washing out of the military, and we spend all this money training, it costs $50,000 to train someone to be in the military, men or women. And they're washing out, they're not even getting to serve the country because of their obesity. When you looked at the data saying that 39 of our states in this country, where 40% of the kids are obese and overweight and obese, we have huge, huge health problems that we're going to be facing in the future with all of the sequelae, whether it's diabetes or cardiac disease and stroke. So those are going to be huge challenges for us, and we're going to need even more providers and more complex care there. So I think one of the things that communication is important. And you talked about having a PA or an NP, and I think we've not done a good job with that. Electronic medical records create communication. The fact that I saw a patient today who I've seen for almost 20 years and sent her for her mammogram about 4 months ago, and it came back abnormal. Short story is she ended up with a lumpectomy. And she comes to me today. I don't have her path. I have her path report, but I don't have her recent follow-up, which says there's a new foci, a new focus of disease there. She had no clue what went on. She said, I'm totally confused when I saw the medical oncologist. And she said, can you help me understand? Is there a note back to the primary care? The lack of communication amongst ourselves and the over-testing we do. So I don't know if she's had her CBC done, or I don't know if she's had her electrolytes checked. And then you spend either time trying to find those, or you redo those. So the cardiologist is doing them, you're doing them, the oncologist is doing them. So I think communication are going to be a key strategy amongst ourselves, and I think technology is there. I mean, we could do some e-visits. Why couldn't I talk to the patient here and just say, how are you doing? It's a day post-chemo, or, you've now been 3 days without smoking. That wouldn't take me long. They're not in the office. They didn't have to drive in there, and it's more efficient than the waste. So communication, and I think we have to decrease the waste. We overtest to cover our backside because we're afraid of lawsuits, but also because we're not communicating well and we waste. We overdo things.
I think you have two people at least on the other side of the table who would agree with that. Fred, how would you deal with the issues that she's talking about in terms of quality of care?
Well, I think the other thing that we're facing too is this whole notion of specialization, and I worry about the death of the community hospital. If you're diagnosed, and myself included, I'm no different. I'm a recipient of 2 hip replacements, but when it came time for me to make that decision, I chose a hospital in Manhattan that had a very low infection rate, because I did my research as an educated consumer, and I had a very positive experience. What that did, though, was take that opportunity of revenue away from my local community hospital, which I will rely on if I have chest pain, if I need 6 stitches, or any other kind of emergency for myself or my children. So what's scaring me nationwide, because I, like Cynthia, go around a lot of part of the country, is the death of the community hospital. We've had some deaths right here in the greater New York area. We got one going on in Lower Manhattan, St. Vincent's Hospital, 165-year-old tradition, right down the tubes. And we're not coming up with solutions as to what's going to be put in that real estate. And I think it's a big problem. Again, this relates to access and convenience, but I think as consumers, we're seeking out this specialization. If we get diagnosed with cancer, we want to go to a cancer hospital. If it's an orthopedic issue, we want an orthopedic hospital. If I have to get eye surgery, I want to go to a hospital that does eyes. And I think a lot of us are becoming sophisticated because of the internet. How has it changed in long-term care? I think for me, we're seeing a lot of sicker patients. It's not uncommon. I think one of the big problems is readmissions to hospitals. We don't really get to eyeball the patient before they become a resident in a nursing home. So it's not unusual for us to flip them. In fact, we create a lot of business from Stony Brook. Last year I accepted admissions from about 45 different hospitals. Some of them, when they arrive at the home, are not doing that well or should have stayed in the hospital a day or two longer. They wind up flipping to Stony Brook Hospital, which is right across the street from the Veterans Home. What's the problem? Well, guess where all their medical records are? Guess all the repeat testing that we're doing? You know, I'm a little excited about the whole notion of Rio and the regional health information organizations, even for simple things. For instance, a nursing home resident that gets brought to the emergency room, we can now electronically send their proxy and their DNR. Sounds like simple pieces of paper, but they can really impact the care that's going to be given to that person. Flip side is when they're discharged from the hospital back to the nursing home, we don't have to wait 8 days for the discharge summary, or my doctors can look at the lab test, or my doctors can, through a PACS system, be able to read radiology tests and see the actual tests. So I think we're getting there. We've got a long way to go. And what also frightens me is all these different systems. We have a lot of smart people in this country, especially on the IT side, but let's come together and agree on some standards. We're not creating 8 different systems, and then to interface these systems is just like a lot of money. So,
Craig?
Well, I would definitely say, especially being part of the Rio group, that it's going to make a major impact on healthcare in this country. It's in its early stages, and it will grow tremendously to include community health data that comes from the primary care provider, whoever he or she may be, and the pharmacists and all the other issues. But I really want to step back and think about something that you said, and I agree with you 100%. Chronic disease and longevity is an issue, and it's an issue in many senses. First one is economics. So when my dad was older, and he went on Medicare at the age of, I believe, 62, he died 69. But now we have people who are reaching 65, which is beginning, and living to 85, 95. And at the same time, what happens is that the payers, the end for the payers is declining rapidly. Why the people who are the receivers are growing rapidly, and they're staying here for a long time. So if you look at it purely from an economic model, you say it can't work. It just cannot work. Something has to change drastically.
There is a question to you regarding, let me just go back up here.
Okay.
Because, with the present legislature, as it stands for physician assistants regarding not being able to practice independently, how do you see the PA's role in community health records? Keeping community health records, I suppose that's related to being involved with community health. But I'm not sure.
I'm not sure
about the question. You know, I think what she's trying to ask is how independently can a PA practice, and I think you answered that by saying that technology.
And I think there is movement in the country to give freedom.
Right. Well, I mean, practicing independently and thinking independently and autonomously are two different things. I think the strength of the PA profession has been that close bond with physicians. But in my practice, I'm in family medicine in a federally underserved area of Connecticut. We do have those. They're not all Greenwich. Eastern Connecticut is underserved. The physician that I work with, he's in the hospital seeing patients, and I'm in the office. And those patients would be people who would not have had an appointment or been seen because he's in the hospital seeing patients. So he's not in the room with me. So I think independently, I think autonomously. But I think it's very important that we work on that team, and I share that. My notes are clearly written, so since I only work 1 day a week as an educator, I'm there 1 day. He knows exactly what I've done, or we consult with each other. He'll come get me and say, you're the GYN specialist in the office, come see this patient for me, or you know rashes, I don't know rashes. And I'll go to him and I say, I need an internal consult, I need another set of eyes. And I think we need to do more of that and include, throw the net out a little wider to other healthcare providers, again, using our nurses better, using our nursing assistants better, using our medical assistants better, because the more people you have involved, the more comprehensive care you're going to give to your patient. So I think PAs really do, the independence word, who cares about hanging a shingle? It's more important that you work on that team. We shouldn't be getting out in silos. We should be all coming together.
Yes, and in fact, nurse practitioners, not to interrupt you, but nurse practitioners are dependent in that sense, that they have a primary care practitioner that they do consult with, and any specialist. There is a question about LIPIX.
LIPEX.
LIPEX.
That's the
Is that going to help?
That's the Rio on the other side.
Is that going to help with us, with this,
Yes.
from one student?
The
How
answer is
that?
yes.
Yes,
Yes?
absolutely.
Right, but here's
It's the
another.
same.
Go ahead, Fred.
One of my other thoughts is that we have Rios, and I don't know what the number is nationwide, but we have some of the best minds creating hundreds of Rios around the country. And
Could you explain both what LIPIX and Rios are
it's the Long
our-
Island Patient Exchange,
Yes. for some of our
X
students?
something, I don't know.
Right.
But it's a Rio, it's the name of our local Rio. But guess what? We got the Bronx Rio going on, we got the Brooklyn Rio going on, we got the Omaha, Nebraska Rio going on. So all these Rios are in the development phase, and I think what's going to happen with Rios is no different than what's happening with banks. Everybody's going to merge eventually until we have, 2 or 3 super Rios. My only frustration with the process is that we have a lot of great people, great minds working on this, and I do believe, I would love to hear Craig's thoughts on this, but there's a lot of duplication going on as we speak for things like the legal issues, for things like the HIPAA issues, HIPAA, schmippa, here we go,
Wow.
I can tell you, I would want you as a practitioner to know my information in an emergency, whether it's my past history, my blood type. So these are all issues that we really, the whole consent process, who gets the information, who doesn't get the information, and how do we make that happen or not happen?
So the Rio is,
Rio is the Regional Health Information
Information.
Organization.
okay.
Which is now changed, just so the audience should know, it's now called HIE, which is Health Information Exchange.
Is this
They
a-
dropped the Rio.
So is this an attempt then to decentralize this notion of e-health, if you will, to try and incorporate into the regional areas, whether it's Omaha, Nebraska or Long Island?
Let me give you a simple example. I have an 85-year-old mother who I love, and I get to accompany her on every doctor visit. And here's what happens when we walk into the specialist office. There's a woman behind the reception area. She's got this large hairdo, and she's got a clipboard. And on the clipboard, there's 9 pieces of paper that I get the pleasure of completing on behalf of my mother, and then she just gets to sign the part where they're seeking out the patient's signature so they can bill the Medicare program or whatever other insurance is there. And this is why we need HIE, because I just want to go in, give her secret code, and have all those forms instantly completed, and I can go back to read some old magazine from 2 years ago that's in that doctor's office. So I think that's where we're going with it. And I myself, even though I'm advocating for my own mother, I can't be sure as to what medication she's on currently, and what's the communication among maybe 2 or 3 different pharmacies that she goes to, because it might be convenient to go to this pharmacy on a Monday, and I happen to be here on a Tuesday. So Rio is going to bring all the lab tests, all the radiology tests, all the prescriptions, all the consults, everything that's out there into one system. And as a child of elderly parents, that's a big deal for me, because time is precious. So I don't really want to sit in your office for an extra half hour and fill out 9 pieces of paper. I want to get my mom the care she deserves, and move on to the next thing. So
Cynthia, let me just take that comment that he just made. Time is precious. We're all agreeing that, yeah, this will save trees, as some of our students have commented, and it is a system of standardization, which will obviously help. But, what type of time do you think we're going to save in the end, and how are we going to reutilize that time appropriately? How do you think we should be utilizing that time?
I think information is powerful, and whoever is treating the patient, if they had all the information that they can get. I mean, you talked about knowing what drugs your mother's on, no matter what pharmacy she's having. If that doctor prescribes, they're going to know what drugs they're on and what the dose is and how, the start and end date, if it's a drug like that, or a drug she has to take for a lifetime. So I don't really know how much time it's going to save, but I think it's less errors. Right?
Okay, so
that to me is
The
less
patient
errors.
safety.
It's patient safety, because you could have situation where somebody went for, we were talking about, going for pre-diagnostic things. You go for a mammography or a pap smear, and maybe it didn't come back. Something came back negative, but it was an HPV, and they said come back in 6 months. The patient goes, I've seen this. They go back, comes back again. They don't have cancer, but it's something else, and they tell them to come back again. And no one was communicating this to the patient. The only reason I know this is because I have friends that this has happened to, that once you're in healthcare, everybody thinks you're a doctor too. But I think that the labs aren't, the doctors aren't communicating. They're busy. They're not like saying, okay, we got to really investigate this patient now. It could be hormonal. It could be anything, but so the patients have to be educated too. I mean, not everybody.
So health literacy is something that
Absolutely.
Okay.
I am so glad that I am in the healthcare field, because to be a layperson in this is even more scary, because, unfortunately we have patients out there that depend on the medical, system out there, and they need to ask questions. I mean, even if someone's diagnosed with cancer, I go back to cancer because that's what my specialty is in. I always get asked, like, well, what do you think? And I say, you have to get a couple of opinions, because you could have 10 medical oncologists and there'll be 10 different regimens. But the key is what kind of cancer they had, to ask that physician how many patients with the same diagnosis, what was their survival rate, what's the side effect profile. Without these, again, electronic medical records, they can't even pull that data, to even tell that patient. So it's scary.
I just want to add that, especially our HIE here, it's not automatic. That the patient has to say that they want to join the Rio. It's not the physician.
It's buy-in.
They have to have buy-in. So we are working on literature to educate the patient of the benefits of joining a Rio. And then, having said that, they also have the ability to select what kind of information they want moved. So they do have some specificity in there. And so if they're coming from one hospital and they're suffering depression and they don't want to move that information around from place to place, they have the option to say, I do not want that information moved. So when they come to this hospital, they come from a primary care facility and they show up here, they have to say, I want this information released to Stony Brook and vice versa. So it is controlled. One of the problems that we're seeing early is in the emergency department, is that when patients come in and we have access to all their records and they give us access. So if you're an ED doc or another healthcare provider, how do you begin to look at, there are certain pieces of healthcare information that an ED doc wants, and that's medication, as soon as they walk in the door, especially if they're showing any kinds of sign, psychotic, and it's hard to get at. There's so much information available now, so they're trying to design screens that would be specific for different areas they're going to use the information. So that's important to know. But it's definitely beneficial, and it's very costly to implement this system. But once it's there, it's there.
Yeah, I think one of our students just commented, you need the electronic card.
That's been talked about.
Is there a cost to the patient to join the Rio?
No, not at all.
Okay, that was a question. Okay, we have another comment.
Not directly, anyway.
Cindy?
When you said, what would you do all that extra time? I have to tell you, when you spend a good portion of your time in family practice sitting down with the patient, I start with a review of all their medications to see if that jives, and then I look at consultants' reports. If they go to see the cardiologist, I like to look at that report and see what did the cardiologist write down as the medications, because sometimes those don't jive. And so using that time, here's a novel idea. Let's talk about prevention and wellness, that we could spend that time instead of doing those kind of tasks that can take a lot of time in your visit, going over when did you have your mammogram, putting that on the flow sheet, looking at what medications they're on, and that really does consume a lot of the time in our visits. So I think we could use that, much better use that time for prevention and wellness and implementation of those kinds of strategies.
You touched on health literacy, and that's really another key component. As you know, most Americans read at about the 8th or 9th grade level, and most medical literature is at the 11th to 12th grade level. And so people that look like us, who hold jobs, who have families, are people who are actually very illiterate. And so to be able to take your medication, or, you know, we talk about making an informed decision about your health care, we have to really go back to some basics, and I agree, we are not ready for any of that at this point. But to talk about even being able to understand how to take your medication is a huge challenge for many people today. And then you add the elderly on top of that, where they have, you know, just the aging process with hearing and visual impairments just as part of the aging process.
And no DNR.
And no DNR. And then you add that with what medications you're taking, and with generics, though generics work well. But I have to tell you, when my grandmother, and you know, she has passed, but when in the 1970s, when, you know, she was my grandmother, she knew her yellow pill was for her congestive heart failure, and her pink pill, you know, was for her hypertension. Today, their Coumadin dose and their Coumadin pill, just the color and the shape could change every time they go for a prescription. And you wonder why we don't have more elderly with bleeds, with the concoctions and the crazy recipes. You know, Coumadin, my favorite drug to hate, where you bring in, you know, I have 70-year-old patients who will come in and they'll say, okay, what did you eat? And, you know, we give them the stance, take one on Monday, Wednesday, and if the sun doesn't shine, then you'll take 1.5. And then we go and we change the color of their pill or the size of their pill because it's a different generic house. It's those kinds of things create huge safety issues for me. And so if we could standardize and use these health information records, I think we could do better medicine.
There's a question I think really related to you, Cynthia. With the current electronic systems that we do have in place, and there are some, for example, with e-prescribing, which I think is the one that has really come forward more than any other, has quality been proven to be improved, quality of care?
Well, the nice thing about the e-prescribing is, at least, and I deal with these pharmacies across the country, and it's not your retail pharmacy for some chronic disease. It's the chronic disease where the e-prescribing is real important. Because a CVS, not to knock CVS, a chain pharmacy, is not going to call the patient and say, did you take your pill? Yeah. But a specialty pharmacy will. And that information has been powerful because they actually communicate with the doctor's practice to let them know that, especially if it's someone like rheumatoid arthritis, Crohn's disease, even diabetics, of course oncology, obviously, they do get that information back to the practice because there's so much oral drugs mixed now with these protocols and these clinical pathways. The oral drug takes play in it. If you have someone going for infusions for 6 weeks and they're not taking their orals, everything is a waste, to the healthcare plan, not to mention what the poor patient had to go through. So it's to manage that patient is very important. And
so you're saying specialty pharmacies are already developed?
Yeah.
Even in urban areas where you have underserved populations?
Maybe you should define a specialty.
Yeah, a
specialty pharmacy is it's not a pharmacy that anybody would walk into. They could be in a high-rise office building. You would never know there was a pharmacy in there. It's not something like what everyone thinks of a pharmacy, your quarter pharmacy store that you could go in and you could buy Band-Aids and seasonal products and get your prescription filled. Specialty pharmacy is a pharmacy that treats chronic diseases and expensive drugs, because these drugs are not inexpensive. And that some of them, need special instructions, patient education, and they work concurrently with the physician practice to let them, that they could make sure that patient is taking the drug. Compliance is the biggest issue with these drugs.
It is with all drugs.
Right. No, it is with all drugs.
Really?
No, but see, if you go to CVS, no one's calling you. You might get something stapled to your bag telling you side effects, and call your doctor. There's another thing. A lot of patients, I've learned this from the cancer patients. If there's something bothering them, sometimes they don't want to tell the doctor because they think they're not going to get their chemo. There's this whole education thing, and it amazes me. But they'll tell the nurse practitioner or the PA. It's funny because I've shadowed patients in practices, across this country, and I'm always amazed because I encourage them. No, tell the doctor. You need to tell them. But it's I still believe that the e-prescribing is one of the best things that has come out. I'm a real advocate for it. I'm a real advocate for EMRs. Over close to 30 years ago, I introduced one of the first EMRs in oncology. The physicians didn't even have computers in their practice. I literally shadowed with a laptop running around after doctors and nurses. And I felt like everybody was dinosaurs because they wouldn't buy into the concept. And now they're being mandated. If they only would have got into it years ago, we wouldn't have a lot of these messes, because there's so many duplications of these poor people, the blood tests that they take, that's unnecessary. There's so many duplications of tests that if everyone had the records, you could have a person that has to go to they have a thyroid problem, so they're going to the doctor for the thyroid. They have they have arthritis, they have joint problems. They're going to 6 specialists plus their primary care doctor, and nobody's talking. There's no communication.
No quarterback.
No, and not only that, a lot of these systems, you were talking about interfacing, they don't communicate. They're, that's the problem. Nothing communicates.
So we're talking about several things that, in regard to the challenges in the organization. If we know, as Craig had mentioned, that the incentive to go into primary care is not there, even if you did incentivize all the medical school students who are graduating, you still would not have enough primary care, or as we might call them, quarterbacks, physicians, whether they're nurse practitioners or physician assistants, they still need that quarterback, so to speak. Then how would you say that the more interdisciplinary approach can really be implemented sooner? Let's start with you, Craig. We're talking about a more interdisciplinary approach. You said a few things. Do you think this organization or institution is geared towards that? And I will add, just as a footnote, that the CEO of this institution has said 2014 sounds like a good year. I mean, can we afford to wait 4 years?
No, we can't. But I believe that this kind of concept comes from leadership, and leadership changes. And coming from the School of Health Technology Management, when Dr. Pellegrino was here, it was the emphasis of healthcare, not here only, throughout the nation, that it was an interdisciplinary team approach to the patient. And I can remember exactly on certain days, we would take all of our students out of the clinical and bring them to the lecture center, and we'd have patients, and every provider would get up and say, and they'd have a case, and they would talk about their role in that particular case. And so we began to understand, when do you need a respiratory care person? When do you need a lab person? What do they really do? Because sometimes you don't see them. It's a difficult task, because we go back to scope of practice, turf, whatever you want to mean. Who's going to get paid for this? Am I a cost item, or am I generating revenue for the hospital? So all these issues are always there. It's difficult, but I believe, we have a very, very sophisticated simulation lab here at Stony Brook. And it gives us an opportunity to get people around technology that will teach us the roles that all of us can play in better delivery of healthcare.
Do you think that a forum of healthcare specialists, as you described them, where you all saw each other's way of thinking, in other words, the mental models that we have about the way we practice in our professions, do you think that's something that has to be reinstituted? Because I was also fortunate to be a product of that.
Yes, I understand. Yes, I would agree 100%. And I'll give you a perfect example. As the Dean of the School of Health Technology Management, I went down and every year, we have PTs, OTs, the whole gang, I do exit interviews. I shut the door away from their teachers and everybody else, and I say, okay, here's 2 hours, here's lunch on me, let's talk. What's working, what's not working? And anatomy, they do human anatomy here, and it's one of the most popular courses in here because they really get the feel. But the question at the end, I would ask each class, how much do you know about PT? How much do you know about Clin Lab? How do you know? Do you have any friends in that area? And many times I would get, no, we're too busy. It wasn't that they didn't want to be friends or learn about their profession. They were so focused on it. So we tried it. So we went to the anatomy lab, because we knew they all loved it, and talked to the faculty about putting a team around the body instead of putting, and it worked beautifully. You talk to them now when they go on their exit interviews after leaving, they have friends in the other departments. And where did you meet them? Around the cadaver. And it was so great because we didn't know this and they knew that, and we got to talking about what we're doing. So it can work, but it has to come from the top down. It has to be done by the leaders. We have to sit around the table and say, our goal is to produce, whether the rest of the world is doing it, our goal here is to produce the team that's going out and everybody will respect and understand each other's role in the delivery of healthcare. We know that it's just not the physician. It's a whole team. It's a
We
very
know it's
large
not the
team.
physician. Fred, how do you think about that? What do you think about that? How would you do that in your institution?
Well,
If you had the best of all possible worlds, how would you?
Well, I actually believe we do have the best of all possible worlds because I have full-time physicians who work in my nursing home. So for 350 beds, I have 5 physicians who are double boarded in internal medicine and geriatrics, and that's not the norm. The norm is that most nursing homes, all 17,000 or most of the 17,000 nursing homes across the country, are using community physicians. So now the community physician practices all day in his practice, runs to the hospital to take care of those patients who were hospitalized, and then maybe if they have time, they'll get to the nursing home to see your grandmother or grandfather and try and provide some kind of medical guidance. That model doesn't work because nurses, LPNs, and RNs spend all day long trying to play telephone tag with the physician. So if you're talking about a waste of time, there it is right there. In my model, my physicians come to work every day in the same institution, and they don't moonlight anywhere else. And I believe statistically that the quality of care is a lot better. I think we're managing those chronic diseases a lot better. And I think in terms of a length of stay, my length of stay tends to be a little bit longer because we're keeping people alive because of the care that it's being rendered.
So is that analogous to what we would call a hospitalist in an acute care hospital?
Pretty much. Although I will tell you, my geriatricians don't like to use specialists. They like to keep it within their practice. They will tell you that they know enough about gynecology or urology or all the other subspecialties. And guess what? If someone falls out of bed and needs 5 stitches, we don't send them to the emergency room. We suture them right at the nursing home. So they're all, to their credit, I think it's a model that really works. I would, and I'd be a big advocate for that kind of change going forward. Here's the problem. It all gets back to how do we earn our incomes each and every day, physicians included. So if I'm a geriatrician and I have a new admission to the nursing home and I'm going to spend 2 hours now with the patient and more importantly with their family to get some kind of family history, and now I've sorted out, because for the past 30 years mom didn't have a healthcare proxy or a DNR, and I'm there with all the families sorting everything all out and we're getting it all arranged. At the end of that 2-3 hour session, the geriatrician has accomplished so much, but there's no CPT code to bill for that stuff. Okay? Meanwhile, if I was an ophthalmologist, in the same 3 hours, I could bang out 12 cataracts, and each cataract comes with a certain amount of reimbursement. So the reimbursement system for specialties is so misaligned. One of the things you're going to learn about the new Health Care Act is that there is going to be a panel of about 12 to 15 people who are going to decide who gets paid what.
That's scary.
And, already we're hearing from cardiologists how their fees are being cut by 30-40%.
Well, then you have a Mayo, I'm sorry to interrupt you, but I think you then have something like the Mayo Clinic model.
Right.
Which I think when you have, or even Kaiser.
Or Geisinger.
Or Geisinger, and you have those models which are pretty strong because they're obviously fantastic medical centers and you do have salaried physicians who are happy.
Right.
Then these people are not unhappy. They also have time to do research, which is another thing that we haven't even touched upon, but I think obviously touches what Cynthia does in her field because it's oncology. Well, and I think it relates to, I'm sorry,
well, in addition
to what you're doing too.
But in addition to how much money am I going to make in terms of my salary and benefits, what's my lifestyle going to be? And I think the lifestyle part is what's going to change the next generation of physicians, because I think they do want to do a good job. I think they do want to do research, but I don't think they want to spend 120 hours in a practice setting. And, Craig and I, we talk to medical students all the time. They don't teach you the business of medicine. So to go into it and have to pay the electric bill and a staff and benefits and negotiate health care plans for my own employees, that's complicated stuff. So it's going to change.
Fred, do you think that, do you think that with the aging population, there's going to be a shortage of nursing homes and long-term care facilities?
Well, I think the emphasis that I'm hearing with the new Health Care Act is how do we keep mom and dad at home longer, okay? And Craig could speak to telemedicine and medical homes, but let me say this. This is a big change for this country, and the reason is it's not your cancer, it's not your stroke, and it's not your dementia that puts you into a long-term care facility. It's a couple of things. It's the strength of your family and their ability to deal with your activities of daily living, okay? So you look at our panel tonight, everybody dressed themselves this morning. Later on tonight, we're going to be able to feed ourselves at some kind of meal. If we need the bathroom, it's easy to toilet ourselves. Those are all things that we take for granted. When you're dealing with a aging population with a lot of chronic illnesses, what's the strength of your family to keep you at home and to care for you? You know, we came from a farming society with 6 kids. 5 of them worked the fields, and 1 of them took care of grandma. And then tomorrow we switch off and somebody else will do that. That's not how it is now. It's not uncommon for me in my setting to get a call from the daughter in Michigan and the son's in California, but mom and pop are here in Setauket and they need some kind of long-term care, and now they're being long-distance caregivers, and that's where we get involved as a facility. I don't think nursing homes are going away. I think we're probably going to have a need for more nursing homes. I think it's a very honest and, I mean, to try to keep people in their own homes, that's great. But don't forget, when we created Medicare, we didn't expect people to live to 85 or 90 years of age. And what's my average age on admission? I'm seeing people probably between the ages of 85 and 88 who come to me with 9 chronic illnesses and are currently prescribed 12 to 15 medications. So that's what it looks like. And why are they coming? It's because their family has given up as caretakers and they really can't handle them anymore. So those of you out there in technology who are planning on becoming long-term care executives, there'll be jobs for everybody. Don't worry about it.
Okay, Greg, do you want to respond to that?
I certainly will.
Very good.
I think the nursing homes, most of them, and correct me if I'm wrong, Fred, are mom and pop in this country.
Right.
They're small.
Yep.
So they can't afford to bring in a physician. And maybe that we need
That's
to
right.
produce somebody at a lower level that can manage the patients for them. But having said that, the problem is that I see, the major problem is people don't want to go to the nursing home for a lot of reasons. I mean, social, they love their home and things. But the economic impact on the home, so if you take a husband and wife that reared children all their lives and they've paid off their mortgage, but they're not wealthy, and now they're reaching to a point in their life where they both or one has to go to a nursing home. They don't have, I mean, it's so expensive. Well, there goes the house, there goes everything that you want to leave for your children. So it's devastating to a family. So I think when the term that's used, age in place, is what we use in the industry, means that as long as they possibly can stay in their home, they want to do that. And we do have technology that will help them. I don't see the nursing homes going away, but I see maybe the length of stay becoming shorter.
Right.
So I wouldn't go to the nursing home until later on in my life. So I might have chronic disease, but due to this technology where I can have a conversation with my caregiver and saying, you know, I'm not feeling well today, or, you know, I noticed that my nose is bleeding more often, or I have an eye bleed and they can see it, and you can adjust this. It's there. They're putting sensors in the home now, so they know exactly what the patient does pretty much every day, and they collect that data. And then when it deviates, then they go in and find out why is this changing.
So maybe instead of the iPad, we'll have an application on our phones that will have
It's truly coming.
our ability to communicate with our doctors or the medical record.
And the family, it's not always the family's fault because, you know, the husband, I mean, the son or the daughter has moved to another state because of a job, but they still want to take care of mom. And what the visiting nursing service sees is that when they go in, and they're using the technology because it's a return on investment. Instead of sending the nurse there, they can use the technology, and the profit margin becomes better for the industry. Makes sense. But what happens is it's a payment for an episode of care. So it's a 60, 90 day, 120 a day. And so what happens is they bring this nice technology in there, and then the daughter, it's usually the daughter, that says they're taking care of mom, because they're monitoring her, they're making sure she's taking the meds, she's taking her vital signs, and it's being looked at. So I feel comfortable. I have my own children. This is a sandwich generation, and I go to work at the same time. So it makes them feel good. But then after the visiting nursing service pulls away, they take the technology away and the service, and now what do? So they're back to square one. So there has to be an infrastructure put into this country, either to have lay people monitor and be the interaction, or to have community people that are retired say that, I'd be glad to look at the computer and have a conversation on how so-and-so's feeling that lives on the other side of town. And, there's got to be a new infrastructure.
One of the projects that the class had was to look at Sick Around the World. I don't know if you're familiar with the PBS film. It talks about different healthcare systems. And there are countries that actually reward the primary care or the community health worker and the community doc. Why are we the ones who want to reinvent the wheel? To make a brief.
But I want to change that a little, because I think here, and I still remember the picture. It was an article, and I don't know what journal. It was a physician in the emergency department, and he was angry. He was truly angry. And an article says, there's something wrong here. And what he was saying is that he has poor people coming into the emergency department who have chronic disease, who are alcoholics, possibly drug addicts, and they don't have anyone to manage them or talk to them about it. So they get sick, they come to the hospital, we take care of them, and then we send them back home, and 2 months later they're back again because there's nothing else. And the addict says, oh, when I get bad, I go there. It's free healthcare. So, it's a big problem. There's nothing simple in our healthcare that we can say we're fixed. We've been doing this too long, and it's been costing us a fortune. And to switch it back to something that makes sense is going to really take a lot of thought and a lot of time.
Yes. And with that, I have another question very related to that. We'll go back to Cindy. People are asking, how do we do this and create jobs and save money? How do we save the jobs, for example, the jobs of nurses? How do we create a new member of the healthcare team? Do we improve, how do we implement these technologies and not reduce jobs? So we create new jobs with this.
Well, one of the things, you do have to start from the top down, but I think you also have to start from the bottom up, which is at the educational level. And in our system, we have, again, siloed ourselves in our educational system so that all our professions say, well, there's nurses here, and there's docs there, and there's the PT department down the hall, and that's just it. Everybody's down the hall doing their own thing. And so truly using an interdisciplinary approach to medicine. I will tell you, we've started to pilot some of that at our school at Quinnipiac, and actually worked outside of Quinnipiac, working with other schools in Connecticut through our AHEC, the Area Health Education Centers. And just recently we went up to the University of Connecticut, and we had the nursing students, we had the physician assistants, we had the med students, and the pharmacy students. Within minutes I said, get yourselves into groups where there's a mix of you. I don't want to have to sit here and say, you go there, you go there, you go there. And they did that within minutes, and it was just amazing as we presented the case how people would step up with just various aspects of the patient care. And we have to start, so I believe we have to start at the educational level, that we really have to go interdisciplinary. I think, Craig used the model of anatomy and how excited the students became. They've known only this very structured, very independent form of education. If you're in PT, you train with the PTs. If you're medical students, you train with medical students. And we throw that term around of team practice very loosely, because in our institution, if there are PTs or OTs or nurse practitioners or PAs, well, they're here, so we work on a team.
But it's different when you say, when we round in the morning, we have a pharmacist with us, and she actually looks and says, well, I really actually would change that medication on that diabetic. And allowing, and again, I think, the scope of practice is huge. If I did a straw poll right here and said, who knows medications, who knows drugs better than anyone, I think we'd all raise our hand and say a pharmacist. And then if I asked the medical community, and would you allow a pharmacist to change your prescription, I think the hands would go down. Maybe a few would go up. But I think we have to look at that. Why wouldn't you allow a pharmacist to say, gee, Cindy, these people are on X, Y, and Z, and there's an interaction here. Did you ever think about that? And again, not faulting me, because I'm handling the medical aspect, and I know medications, but when you mix them like that, and when you're talking about people on 14 medications as the elderly, they're going to be drug-drug interactions. And so we really have to start at the bottom with our educational system in healthcare, and we have to get a real true interdisciplinary approach. It excites the students. I think they'd be more excited to enter areas of medicine like primary care or geriatrics. I have to tell you, my favorite patients, they have the most excitement, they have the most disease to take care of, the worried well. I can only run 20 miles today when I normally run 22, and I run all these tests where you see an elderly patient and they're what they have to offer and bring to our culture. And I think that's another problem, is our society. You talked about PBS and Sick Around the World. I thought you were going to talk about our culture. We don't take care of our elders. When you look at many other cultures, whether they're Greek or Asian or whatever it might be, European, where it's just a no-brainer that we take care of our elderly. And here, it's put them in a home. Can't we get somebody to come in and do it for us? Put them in a good home, exactly. But so there's a whole cultural shift that we would have to see as well. And we fight those cultures here. We fight the different cultural groups here that actually still take that responsibility and are responsible for their elders, and we fight them. We buck that system with them instead of encouraging it. We're a country where we don't provide family medical leaves as easily as they do in Scandinavia or Norway or Denmark or in other parts of Europe. We penalize people, and it becomes a huge issue. So this healthcare reform is the tip of the iceberg. There's so many social issues as well that we need to address.
So as leaders in your own organizations and roles, how do you think we can, what role do you think you can play in reconciling the private good and the public gain? I mean, the private gain and the public good, I'm sorry. Reconciling the public good and the private gain.
You always have to keep patients first. I think for those of us who are really true, and there are many of us who are really, this is what we're here for, is taking care of patients. It's not about me. Me, myself, and I are not my three best friends. It's truly about taking care of patients. And if those of us who believe in that step up as role models, and we really do have to mentor individuals. You heard these folks here, everyone, mentoring, shadowing, helping people. That's really our responsibility. There clearly are opportunities here when we talk about things like technology. There are opportunities for technology companies to develop better processes. But I think those of us who are healthcare providers and say put patients first, primum non nocere, do no harm, if we are true to that, then we'll hold those people's feet to the fire so that it's not all about making money. That pendulum has swung far to the right with everything is about making money. And, oh yeah, by the way, yeah, we'll do that to help a patient. So I think we need to take an individual responsibility, and I think those of us who do it really have to step up and mentor those that are coming through, our students and future healthcare providers.
Cynthia?
Well, I think that, our providers, they're just like you are, they care about the patient. I mean, that's what they're in this for. The challenge that they have is like dealing with the insurance companies. I've seen medical oncologists on telephones with a clerical person at a healthcare plan trying to get something approved because the doctor might need some extra diagnostic and they won't approve it. Or it's a drug that particular healthcare plan doesn't have on their formulary, but it's the only drug that regimen that patient really could be on because of their disease. And they have to go through all these steps to try to help that patient. The doctors are the patient advocates. When you have physicians spending a lot of their time on the phone with healthcare plans, it's scary. I mean, I see the healthcare reform, but I didn't see the insurance companies get slapped too hard in the 200 pages or whatever it is, at least from what I could see. I think that's a real thing that has to happen here, because we can't have people, if somebody needs the care and they have to get, served. I'm a patient advocate. In my career, I've gotten more free drug for patients than I can talk about. It's the only thing that makes me happy. I have a situation, I work for the Greater New York Hospital Association, one of their companies, and I was sent up to a hospital in Poughkeepsie where the hospital had a lien on a young woman's home. She was 42 years old, owed over a couple $100,000. She had breast cancer. She was HER2 positive. And I was sent up there to try to help their receivables. And I went and I said, well, why everything was right. They did the test. She was HER2 positive. The doctor did the right thing. It was the only drug that the patient could be on. And the healthcare plan didn't have it on their formulary. Obviously, they didn't have this drug on their formulary because it was a small plan. The pharmaceutical company, who is very large, I want to protect them, but they're out in San Francisco, big biotech company, never bothered to work this little healthcare plan in the Hudson Valley. So, I was able to get free drug because I threatened to go to the Wall Street Journal with this and the New York Times because I wanted to hear this woman and her husband and their small children. I didn't even know these people, but I was like, God, they're working, they're doing everything right, and now they got a lien on their house because they can't pay this bill because this drug is so expensive. And I think that's the other thing. I think the drug companies aren't putting in their share to this either. I worked for 2 pharmaceutical companies. I launched a major drug in oncology. I know the profits. I know the cost of these raw materials. It's frightening. And the United States pays for all the drugs in the world, because in the other countries, I launched drugs in Europe, South America, and Canada. That's something that I did in my lifetime, and it was so much easier to launch a drug in South America, in Europe, and Canada, because it wasn't about what we were going to charge for the drug. It had to fit into they have all this disease management, so they only allow so much for breast cancer or ovarian cancer. That's what this drug was for. So how I had to price that drug was how it was going to fit into their model. Now in the United States, where everybody's making money on it, the person pays more for the drug. That's why Canada's drugs are less. The same cancer drug in Canada is much less than it here is in the United States, which is bad for the system because the co-pays are higher for the patient. If the patient can't pay the copay, the doctors have to absorb that, or the facility.
So then are you saying then that managed care has not really stepped up to the plate in terms of their ethical responsibility in this regard?
I don't.
Because it certainly haven't saved us on costs.
No, because if you look at some of those CEO salaries, I mean, I'm sorry, I'm not an insurance advocate by no means, because I've seen some of the things that they do. Do you see that the Healthcare Reform Act is going to address that issue at all, or do you think it's caved into that?
I haven't gone through all the pages. I keep getting snippets. I go to, I myself go to different websites. I was on the Kaiser website, looking at things. I was on the ASCO website, which is the website for all the medical oncologists. It's the World Congress. And I haven't seen anything on the insurance piece. I don't know if that was addressed, because I don't see them, I don't see any changes for them. If they're going to dictate the costs, it's sort of like the government, like on these Medicare drugs. I believe the government should buy the drugs, because the government pricing is so much less, but yet they allow people on these Medicare Advantage programs to make money. To me, that's ridiculous, because the pharmaceutical companies have pricing, government pricing, and there has to be
everybody else.
And there has to be the government pricing has to be 15% below any published drug price. So why can't the government just buy the Medicare drugs? This Part D was a debacle when it first came out. I had, at that time, my parents were both alive, and I had them on a New York State program called ARP that I paid for them. And I told them, you're not going on this D, keep whatever Social Security you're getting, because between the donut hole, not having all the drugs on it. Now, I was fortunate. I had a parent that wasn't on any pharmaceuticals because he was healthy, and a mother that was on a drug for angina, so it wasn't like a big thing for them to be on this Part D. But they never even looked into that, where I thought, why don't they just buy the drugs? Because then the drug companies have to sell it to them at government pricing, right?
So in fact, maybe what will happen then with the HMOs, since they're not going to make any less money, in fact, they probably make more money, their risk pool will just increase. So they're going to get more of the uninsured right
Right.
now.
That's what they're
Oh,
complaining
yeah,
about.
well, there's gonna be
It's a
32
risk
million
pool.
people,
And
and, yeah.
they can't do anything about it now that we don't have the quote public option.
Yeah.
Right,
But-
Fred?
But there's also,
I mean,
there's-
even the HMOs have one stipulation, they must take a certain amount of percentage of Medicaid patients.
But I
They're
think,
managed Medicaid.
but I think, I think
But
public,
eventually the
I think
balance will
public
tilt,
option
don't you
has
think?
always, I think public option has always been a misnomer. Because we have a public option, it's
Medicare,
called Medicare and
Medicare.
Medicaid.
that is
Yes.
our
It is,
federal
and
program,
here's the
yeah.
other thing, and if you haven't
Yeah.
heard this, the new Healthcare Act is creating 150 new federal agencies.
More government.
If that doesn't frighten you, then nothing will. I mean, we have existing, I do a lot of work with the VA on Vermont Avenue in Washington DC. I can tell you that the bureaucracy of this one single agency, and at the end of the day, I do believe they have a mission, and they are trying to do the right thing for the population they serve, in this case, veterans. But the amount of bureaucracy just to get something accomplished is very frightening. That's one agency. The fact that we're creating 150 new ones,
Scary.
Anybody who doesn't want to be unemployed, move to the Washington D.C. area, because that's where all the jobs are going to be. But, I want to come back to one thing Cindy said, and it's putting the patients first. But for those of you who are going to be part of organizations, try and work for an organization that's mission-based, that has a vision, and that have values. Not values on a piece of paper, but values that are exhibited by all the people who work in the organization. I think my organization tends to be successful because we're kind of like Southwest Airlines from an employment perspective. If you don't know this, Southwest will interview 1,000 people and probably hire 6 or 7 because they want people with the right attitude. And it's not hard to train people how to give out pretzels on an airplane. But getting the right people to work for you, you can't have a team concept unless all the employees who work for your organization buy into that team concept and believe in the mission of the organization and believe in the vision of the leaders, okay? Because most employees want you to take them to a better place, and they want you to tell them when we have arrived. And that's a very important piece to this stuff.
Well, if Crane's business is saying that hospital CEOs are also making the big bucks as much as the HMOs, how do we give that mission to, how do we deliver that message to those individuals who want to work for a company or a hospital that has a positive mission that is for the public good?
Well, here's what employees want.
If they know that.
People want respect when they come to work. They want a job in which they're able to succeed at, that they're not overwhelmed, and they want to have a little bit of fun at the end of the day. And you can do that in healthcare. The question is, how do I align all that to make it happen for all the individuals in my organization? And you go to a typical hospital, and there's hundreds of different job titles at that hospital, including the pot washer in the kitchen. But I can tell you, if I'm going to eat in the cafeteria, I want the best pot washer, because I don't want to be succumbed to some E. coli because the guy didn't know how to wash the pot.
So how do we reward that talent?
Well, you have to find that talent, you have to nurture that talent, and you have to make people want to belong to your organization and are there more than just the money piece. You know what? I don't take anything away from a well-run hospital in terms of paying their CEO a salary that's commensurate with what kind of activity goes on at that organization. It's hard to find good people. You
But
pick
then you
the
have
job
to pay
title.
for that talent.
Yeah, you have to pay for that talent, and you have to be committed to that. That's a very big piece of it. And not every CEO makes as much as the drug companies and the insurance companies.
No.
So while the money's good, it's not as good as some of the other organizations. And the other, we can have a whole session on this. I'm not so sure about, at least on the hospital side and the nursing home side, one of the things that frustrates me is that 70% of all nursing homes in America are for-profit. So, and I'm in that category of 3-4% because I actually work for government. And the other 25% are not-for-profit. When you look at outcomes, some of the better outcomes are occurring in the not-for-profit organizations as opposed to the for-profit organizations. Mm-hmm. So, I'm not against capitalism. I think everybody should be able to succeed in our country. But what is the motivation at the end of the day? That's something we have to look at.
Okay, I'm going to ask for final comments. I have a lot of Comments here. I think they're also talking to each other. Somebody's saying, oh, I agree with him. Like I said, I'm a capitalist. Regarding the public option, example, Medicaid, if someone makes $30,000 a year, they don't qualify for Medicaid and may have to be on a drug like a chemotherapeutic drug and do not have the funds to afford it. So they fall into that crack, if you will.
Big crack.
Well, we need to fix that.
Yeah.
We need to fix that. But to say we have to create this whole new public option with a whole new bureaucracy, I think you take one of the existing bureaucracies we have, like a Medicaid, and change the rules so that if you need this chemotherapy drug for a 6-month period, maybe we cover you so you don't have to lose your house or lose your job or lose your family. I mean, that's the smarts we got to bring to the table.
So then, in other words, we're saying that somehow or other healthcare professionals, whether they're administrators or healthcare givers, have to be lobbying more than they are.
Absolutely.
And we as healthcare professionals have to empower them by encouraging them and making them more literate and not being afraid of malpractice. Because if you encourage people to know, you also have that, the other side of the coin.
Nadia, here's the
Knowledge
problem.
is a dangerous thing.
There's twice as many law schools in America than there are medical schools. So
There you
let's
go.
fix that. Cindy's right, we need to fix that.
Okay, let me see if there are any other final comments. I agree with Fred Skang to expand the public option that is already in place. Medicare, Medicaid, we don't need to reinvent the wheel. Lots of luck. Hospitals need to stay aligned with their mission and vision statements and remember that they are for patient care.
Right.
All right. All right, any final comments from anyone on the panel? And I'll ask for the same from our class. Seems like they all had fun with this.
As long as I'm not on YouTube at the end of the day. That would be great.
Okay, let me give them a few minutes. Okay, Fred, most hospitals don't do end of life well. What is your secret?
Ah, there you go.
there you
I think
go.
that's
Yeah, question.
that's a big part of it. And here's what happened. We somehow in all this healthcare reform, we started calling it death panels, and I think that's what. Okay, but you know what? When grandma or grandpa comes to the hospital without their healthcare proxy and without their DNR order, that's a big deal because, you know, here's what happens. And occasionally when you do the DNR, we put it in the safe deposit box so we don't have access to it, which is the worst place you could put it. But things like a Rio or a health information exchange hopefully will change that. When you, and I don't know the exact quote, but when you look at Medicare recipients, 50% of what we spend on Medicare patients is in the last probably 4 to 5 weeks of their life. Okay, so I had a case where we had sent someone to the hospital. They wound up in the ICU on very expensive care for a 6-week period, and I had the daughter approach me at the nursing home to say, gee, what did my dad's DNR say? And it explicitly said, I want everything possibly done to save me, no matter what the cost and this and that. And I said to the daughter, I said, did you ever have a discussion? You know, your dad is 88 years old. You're in your 50s. Did this ever come up at all those Thanksgiving dinners where you and your 2 sisters sat around the table? And we don't talk about it. And we could have saved a lot of, I mean, the family was angry. The family was hurt. The family's upset because there was Pop being a big pincushion in the ICU, and the outcome wasn't great, and it cost us a lot of money. And I don't think he had any quality of life in those last 5 or 6 weeks. But in the big picture of the economics of it, Craig, that's where the money was spent. So we're not doing enough talking. There's a lot of simple things we can do as a nation. We don't accept death very well, but we need to plan for things like that. You know, in our country, when someone's pregnant and going to have a baby, we spend 9 months doing what? Getting the baby's room ready and buying all kinds of great stuff and giving mom her prenate vitamins and all that kind of good stuff. But when someone's leaving the planet, it's not the same thing. And there are things we can do as a nation to prep for that. A lot of it starts with communication, so even among family members.
There's one last question along the same lines, and then I think we'll close. Several people want to know what you take on preventive medicine, how we can actually focus on that now.
Education.
On this.
People need to be educated. I mean, I'm all for preventive medicine. I mean, I think everyone should go for this family history. That's where the genetics comes in too. You know, if you have a family history of certain diseases, people should go and get checked and just to see. I mean, you know, there's certain things they could do to prevent. Doesn't mean if your mother and father are diabetics that you're going to be a diabetic. You could do some lifestyle changes, or if there's coronary issues in a family, if they go for all this, I think that's very important. But there again, that if you have, like, I've spoken to a lot of physicians that put genetics in their practice, but they could hardly bill for it. It costs more money to have it. They don't reward the doctors that are trying to do that either, because they put someone in, and the billing of it is so, there's not money. It doesn't even pay the salary of the person that's doing it, you know. So that needs to be changed too. But my final word on this healthcare reform, which I'm scared to death about personally, is that nothing has been addressed of non-Americans that our hospitals take. And representing a hospital association, that scares me, because we take everybody. And,
Well, you can't close your doors.
yeah. So
That's right.
So that's another
So does that
issue.
mean we have to become a not-for-profit hospital system?
Well, here's the problem,
Yeah,
and
because-
maybe Craig can address this too. There's X amount of dollars for charity care. So they're planning to use some of these charity care dollars to help the 32 million uninsured Americans get insurance. But if I was a hospital on a border state, I'd be petrified, because I depend on charity care money for all the illegal aliens that might want to use my services. So, you know what? It's a great act. We're making some changes, but we left a whole portion of our population out to dry, and worse, the healthcare providers who care for those people out to dry. So it's a big
So
problem.
we're forcing them to be not-for-profit.
Well,
In
I
other
don't,
words,
whether you're for-profit or
doing
not,
charity care,
here's the
really.
problem. There's not a hospital in America that can refuse you when you come to the front door. That's the one advantage we have in nursing homes. I don't have an emergency room, so you really can't get into my nursing home. And I look for a payer source at the end of the day. Hospitals don't have that
They don't
opportunity.
have that luxury.
They don't have that luxury. And
Well,
it's-
they only have to take you really if it's an emergency.
Right.
So if you end up, they don't have to admit you. So the problem there is they send you back home with the same problem and wait till it gets to
Worse.
an emergency.
Exacerbates, right.
Right.
And then you can come back to the hospital and we can take care of you. So it's a catch-22, and it affects the poor people in this country more than anyone else, because they have no primary care people taking care of them in their community. Their life is a problem. They work hard, many of them, but they can never get out of the hole that society has put them in for a variety of reasons. And then what happens? They don't take care of themselves. There's no one educating them. Who's the one that's eating all the burgers and the French fries and the fructose corn syrup? And it's people without any money. I went to Mississippi one time because they asked me to go down and look at. This is one of the largest populations of obese, diabetes, juvenile people. And I tell you, anybody who knows me knows that when I look at the glass, it's always half full. But when I left there, I just said, there's no way to change this. They're poor. There's no restaurants in town. It's all fast food. You go into the grocery stores, it's cheap cereal, sweet stuff, all the stuff they bring home. How are we ever going to get them out of there unless we infiltrate that community and begin to work with the kids and educate them about eating right and exercise and stuff? But it just seems to continue to me. You look at the parents, you look at the children, you look at the new children that are coming.
The cycle.
And it's just one big cycle. And it's all community infrastructure. It's a public health problem. And we're not putting any dollars to change it. So
We're not
gonna
making
deal with it.
we're not making patients responsible also. I think that was brought in from Dr. Strongwater. He said that was something that should be implemented as well, and how can we do that?
But educated middle-class people do take responsibility for it. It's the poor people that don't. And it's not that they don't want to, it's just that if you look at their life, you know, it's crime in the street, it's a very different environment. And we just assume put them into the side and say, stay there, don't come into my neighborhood. And so what, you don't have health care? So what? I'm angry because you sit in the emergency department all day and get in my way when I need to go. So we really need to change the infrastructure and figure out how to help these individuals.
So on some level or another, we're kind of reinforcing that, whether it's the border states issue, or whether it's those states that, as you say, continue to
Well,
maintain that cycle.
even here in Stony Brook, we do a huge amount of charity care.
Yeah.
It's a big number here. If people knew the number, they would be quite shocked at what that number is. You know, I had the privilege of being the acting CEO back in 2006, and the number is staggering. It's a
Sure.
$5-6 million number in charity care. And you can't close your emergency room. It just, you know, and Craig will say you can send them home, but a lot of them get admitted and stay a while. So it's really not that easy.
They say that St. Vincent's had that problem
Yeah.
in many ways.
Sure.
Any
Well, if you
final
look at the neighborhood.
comments, Cindy?
I think I would just ask all the students or encourage all of you, we've had some good discussion here. I know you've been chatting with each other, but it's not just about chat. We have to put our money where our mouth is, that each of us has to take responsibility. One person can't change as the president, the Congress isn't going to change it, but if we at the grassroots, if we stand up and each of us does a little bit, we actually will make that change. So I would encourage you to keep on with this, not just do it for your class to get your grade, but to find that cause and carry that torch forward, and it will make an impact. So, and good luck with your studies.
Thank you all for attending, and I'm going to stop the recording.